Hello. Today we're going to be talking about dosing phenytoin. Now, I know that this is not a dosing phenytoin class. I'm going to just spend a few minutes talking about dosing and then introduce some clinical tools, and you'll be doing a workshop using those clinical tools in small groups. But this is just kind of wrapping up a couple of loose ends here and why we need these clinical tools to dose some drugs. And in this case, I want to talk about phenytoin since we introduced phenytoin, but didn't really talk about how we actually dose it in in your class. So let's talk about that for a little bit. Um, all right. I have to advance the slide. So here we have a case where AM is a 40-year-old, 5'9", 78-kilogram man suffering from epilepsy. He's needs to be started on oral phenytoin. Please determine a starting dose for sodium phenytoin. What do you want to know about this patient? Well, we have to then go and think about how phenytoin is cleared, um, other particular things about phenytoin. So I'll tell you, phenytoin is cleared by the liver. It's highly bound to albumin, so we care about albumin. We'll be talking about that a little bit more. We want to know if he's ever been on albumin before, or on phenytoin before. We'll want to know about his renal function because that's going to be important for binding. And we also know a special thing about phenytoin, which we're going to emphasize in a minute. So we know it's fairly bioavailable, 95% to 100% bioavailable. It is important to know that it will bind to some tube feeds. So if you're giving it down an NG tube, it could bind to the tube feeds and not be very bioavailable at all because of a physical binding. We also know that it's usually given as a sodium salt, which is only 92% phenytoin. It's cleared by the liver. A low extraction drug metabolized primarily by the 2C19 system. Here's the important part. It's clinically saturable and nonlinear clearance here. So that's very important. Um, the volume of distribution is about 0.7 liters per kilogram, which is about the same as total body water. And we can use actual body weight unless they're obese. And then you can use this dosing weight to determine a dosing weight to base the phenytoin binding on or dosing on. I don't expect you to remember any of this, but know that you can use actual body weight. It's only about 10% bound or 10% free. It's 90% bound to albumin. The half-life is variable because of the nonlinearity, and its half-life is about 8 hours. Therapeutic range is 10 to 20 milligrams per liter. The concentration dependent adverse drug reactions, which again, I think you should always know if you're dosing a patient. You can have CNS. That's probably the most common things we're going to see. The therapeutic range is 10 to 20. So as you get to the high end of the therapeutic range, you're going to see a far lateral nystagmus. And then as you go up, you're going to see that nystagmus become more pronounced. You'll also see ataxia. And as you get higher, you'll see significant ataxia, diminished mental capacity, drowsiness, coma. You can also have seizures from this drug. You also can have gingival hypertrophy that's not as directly related to the therapeutic to the amount to the actual concentration, but you will see this at higher levels. Hirsutism and coarse facial features and immunological disturbances.